Hello, and welcome to this program sponsored by AstraZeneca. My name is Deborah Simmons. I am a family nurse practitioner in Philadelphia, Pennsylvania. I have the pleasure of providing this educational disease state presentation entitled "The Current Misperception of Asthma Control Using Evidence-Based Tools to Advance the Identification and Management of Uncontrolled Asthma Across Disease Severities." Please note, this presentation does not qualify for any form of continuing education credit. Today, our goal is to achieve the following objectives: recognize the burden of uncontrolled asthma in the United States, heighten awareness of patients and clinicians' overestimation of asthma control and the consequences of short-acting beta agonists, or SABA, utilization exacerbations and systemic corticosteroid exposures. And finally, learn how the AirQ and accompanying evidence-based educational materials can help identify and act on uncontrolled asthma. Let's begin with the question, what is Precision? Precision is an unbranded initiative dedicated to improving the burden of asthma. More than 25 million people in the United States have asthma, and of these people, about 62% of adults and 50% of children have uncontrolled asthma. These statistics suggest asthma is common and often uncontrolled, and that new approaches to the identification and management of uncontrolled asthma are needed to help decrease the burden of disease. The Precision program was developed in conjunction with over 200 independent advisors across the United States to produce validated tools to help identify and manage uncontrolled asthma and develop educational resources for both patients and healthcare providers. All right, looking at asthma prevalence over the last 2 decades, we see it has remained relatively stable. As shown in the bar graph, patients with asthma represent 7.8% of the total US population in 2019, a number that has not changed since 2015. Further statistics from 2019 also show a high burden of disease due to an asthma attack at approximately 10.3 million per year. In 2018, 2.2 million children missed 7.9 million school days, and among employed adults, there were 10.9 million missed work days. Mortality due to asthma in 2019 shows just over 3,500 deaths, 178 of which were adolescent or children under the age of 18. The burden of uncontrolled asthma is substantial and projected to increase over the next 20 years. The Canadian Respiratory Research Network projects more than 17 million people 15 years or older in the United States will be living with asthma in the year 2038, and 52% of all patient years with asthma will be uncontrolled. The projected costs associated with uncontrolled asthma, both direct and indirect, will be close to $1 trillion. So let's go back to the basics. What drives asthma symptoms? The answer is underlying inflammation. Along with bronchial smooth muscle tightening, airway inflammation results in airway narrowing, which is the impetus for the development of asthma symptoms such as cough, wheeze, chest tightness, or shortness of breath. It is important to remember that inflammation and symptoms are not constant in asthma. They vary over time and intensity. However, even patients who are currently asymptomatic have underlying airway inflammation that persists and puts them at risk for an asthma exacerbation. There are multiple inflammatory pathways that lead to airway narrowing in someone with asthma. These include allergic eosinophilic, non-allergic eosinophilic, as well as non-eosinophilic pathways, all of which can result in structural changes that contribute to the thickening and heightened reactivity of the airways. And ultimately, rising inflammation can lead to uncontrolled asthma and exacerbations. Now that we've reviewed the pathophysiology of asthma, let's look at the geographic variability in severe uncontrolled asthma. Analysis of a large U.S. administrative claims data set representing approximately 4.5 million people with an asthma diagnosis of all age demonstrated that 15% of these patients were considered uncontrolled when defined by a patient having 2 or more systemic corticosteroid fills in a year, and 14% were treated as severe asthma based upon GINA step therapy levels 4 and 5. 3% of all asthma, or approximately 144,000 patients, would be considered both severe and uncontrolled when defined by a risk definition only. The heat map on the right shows the heterogeneity and the concentration of these patients with severe uncontrolled asthma across the United States. The darker colors represent the counties within the higher percentiles for absolute number of patients with severe uncontrolled asthma. However, it's important to look at another definition of asthma control to truly get a better understanding of the magnitude and burden of uncontrolled asthma. In this same population of patients, uncontrolled asthma was defined by both domains of control: exacerbation risk, characterized as 2 or more courses of systemic corticosteroids per year, and symptom impairment, as indicated by 3 or more canisters of sabafills annually. So when we look across the full spectrum of disease severity, what happens to the number of patients with uncontrolled asthma if both risk and impairment are considered? The percentage of those with uncontrolled asthma increases. Of those with severe asthma, 50% would now be considered uncontrolled, equating to approximately 320,000 people within this cohort. More striking is that 36% of those classified as mild or moderate are now uncontrolled, representing nearly 1.4 million people. All told, 1.7 million people, or 38% of the total data set, would now meet the definition of uncontrolled, regardless of severity. This shows the need for intervention across all severities to gain better control of asthma and to reduce the burden of disease. Here is a study by Lugogo et al. In which we evaluated the heterogeneity between sabafills, maintenance adherence, and severe asthma exacerbations in the United States. The study included over 135,000 US patients with commercial and Medicare insurance who had asthma and were 12 years or older. The results show a significant heterogeneity in the amount of SABA being filled and the associated adherence to maintenance medications defined by medication possession ratio. The percent of patients having 1 or more exacerbation per year rose as SABA fills increased. Regardless of SABA exposure or maintenance medication adherence, roughly half of the patients with asthma experienced at least 1 exacerbation per year, demonstrating that many patients are at risk of exacerbations. Let's now look at the consequences of an asthma exacerbation. Most often it includes treatments with a short course or burst of systemic corticosteroids, or SCS. However, SCS exposure can impart risk beyond just the short course of treatment, with cumulative lifetime doses increasing the odds of developing adverse health conditions. While one burst may not exceed the lifetime high-risk SCS exposure threshold of 500 milligrams, a second burst will likely exceed this threshold, increasing the risk of type 2 diabetes, depression, and anxiety. Burst 3 may exceed the 1,000 milligram threshold, increasing the likelihood of a patient experiencing renal impairment, cataracts, heart failure, pneumonia, or osteoporosis. Overall, it may take only 1 to 2 courses of oral corticosteroids to increase the risk of adverse health outcomes in our patients with asthma. This begs the question, is there a window of opportunity to interrupt an impending exacerbation and the need for systemic corticosteroids? In this slide, we present a figure depicting findings from the FACET study, an evaluation of exacerbation reduction in response to an inhaled corticosteroid with or without a long-acting beta-2 agonist. This work demonstrated that peak flow decreased in symptoms and rescue use increased in the 10 days before an exacerbation was diagnosed and returned to pre-exacerbation or near pre-exacerbation levels over the subsequent 2 weeks. Consequently, there may be a window of opportunity to interrupt the rising inflammation that can result in increased symptoms and increased use of rescue therapy, and thus prevent the occurrence of an exacerbation. Expert opinion on asthma management is now addressing the need to treat inflammation at the time when patients experience symptoms by using an as-needed, fast-acting bronchodilator with an inhaled corticosteroid concomitantly. The latest recommendations from the Global Initiative for Asthma, or GINA, and the National Asthma Education and Prevention Program, or NAEP, support treating symptoms and inflammation concomitantly. In adults or adolescents aged 12 years and older with asthma, both the 2021 GINA and the 2020 NAEP recommendations acknowledge that even modest SABA use may be associated with harm, including an increased risk of asthma-related death. Thus, both documents utilize the evidence that exists for as-needed ICS formoterol as safe and effective way to reduce exacerbation risk. Please note, the use of ICS formoterol is not approved for maintenance and rescue therapy in the United States. The recommendations for ICS formoterol are based on clinical data evaluating the use of ICS formoterol formulations and strengths not approved and not available in the United States. Now that we have seen the extent of uncontrolled asthma and the consequences of exacerbations and associated need for systemic corticosteroid treatment, how do we identify patients at risk? It is important to remember that asthma control consists of 2 domains: symptom impairment and exacerbation risk. Asthma control questionnaires currently recommended for patients 12 years and older by expert guidelines or report include Asthma Therapy Assessment Questionnaire, Asthma Control Questionnaire, and Asthma Control Test, all 3 of which only assess symptom impairment. The Precision program was initiated to develop innovative, validated tools to improve the identification and management of uncontrolled asthma by focusing on both domains of risk and impairment. As a result of the dedicated hard work from the Precision program and its scientific advisors, the Asthma Impairment and Risk Questionnaire, or AIRQ, was developed and validated for use. A cross-sectional study of 442 patients established the final AIRQ questions, scoring algorithm, and cut points to validate AIRQ as a measure of current asthma control measured against a standard of the Act plus prior 12-month exacerbation history. Additionally, a longitudinal study of these same and 670 additional patients was performed to assess the ability of AIRQ to predict exacerbations over 12 months. The development of the AIRQ began with 15 candidate questions encompassing both domains of asthma control, risk, and impairment. A cross-sectional validation study was conducted to evaluate the AIRQ against a composite criterion consisting of comparable ACT scores as a surrogate measure of the impairment domain and chart documentation of exacerbation in the prior year to represent risk. Any one of the following qualified as an exacerbation. 1, treatment with a course of systemic corticosteroids for 3 days or more. 2, any visit to an emergency department, urgent care, or unplanned office visit due to asthma exacerbation. Or 3, a hospital stay for asthma greater than 24 hours. An ACT score of greater than or equal to 20 and no prior year exacerbation set the standard for well-controlled. An ACT score between 16 and 19 or an exacerbation that did not require hospitalization defined not well-controlled. The very poorly controlled category involves either an ACT score of 15 or less, 2 or more exacerbations not requiring hospitalizations, or 1 or more hospitalization for asthma. The AIRQ questions were then evaluated against this composite criterion to determine its ability to similarly differentiate the three levels of control. Models using receiver operating characteristic curves were applied to each of the original questions. Ultimately, the retained questions were selected for their ability to contribute statistically to one or both of two models without redundancy. Sensitivity and specificity results from dichotomous models help determine the scoring cut points that demonstrate the ability of the AirQ to accurately discriminate between the varying control levels. Model 1 on the left evaluated the ranking of well-controlled as compared to not well-controlled and very poorly controlled, while Model 2 on the right compared well and not well-controlled against very poorly controlled. In Model 1, an area under the curve of 0.94 illustrates the ability of the AirQ to differentiate patients who are well-controlled from all others. In Model 2, an area under the curve of 0.93 demonstrates the ability of the AirQ to differentiate patients who are very poorly controlled from all others. The cut point of two or more yes responses to separate well-controlled from all others was set based on the principle of having a high level of sensitivity, 0.90, to ensure these patients were well-controlled, as they would be least likely to receive further assessment. Conversely, a very high specificity level of 0.96 was set to greater than or equal to 5 yes responses as the cut point for separating patients who were very poorly controlled from all others, minimizing the risk of over-identifying those patients who would be likely to undergo further, potentially costly and intensive interventions. Of the 15 items tested, the 10 selected questions result in the questionnaire we see today with AirQ. Scores of 0 to 1 indicative of well-controlled, 2 to 4 representative of not well-controlled, and 5 to 10 identifying very poorly controlled asthma. As a result, the AirQ was created. The AirQ is a 10-item, equally weighted, yes-no composite asthma control questionnaire with 7 impairment items with a 2-week recall period and 3 risk items with a 12-month recall period. So how does this tool help us better assess asthma control? Baseline data from the larger longitudinal validation study of adolescents and adults with asthma demonstrated that asthma control is overestimated by patients, healthcare practitioners, and the ACT, and suggests that exacerbation history may not be formally considered in routine clinical practice. Of those assessed by either patient self-report, healthcare providers, or the ACT, 32% or 220 patients, 30% or 177 patients, and 29% or 159 patients respectively had one or more chart documented exacerbations in the prior year. When these same patients were assessed by the AirQ as well controlled, 15% or 60 patients had one or more exacerbations in the prior 12 months. Since the AirQ includes impairment and risk items, it can provide a more accurate and comprehensive assessment of asthma control, as prior exacerbations are a predictor of future exacerbations. So how well does the baseline AirQ control level predict future patient-reported exacerbations over the subsequent 6 months? As you can see, if a patient was rated as not well controlled, they are 2.1 times more likely to experience an exacerbation in the next 6 months compared to those who were well controlled. For those in the very poorly controlled category, the risk of experiencing an exacerbation is 4.9 times that of those in the well-controlled group. Traditionally, accepted clinical and demographic predictors of poor outcomes in asthma, such as age, gender, and BMI, do continue to show greater odds of future exacerbations. So utilizing an instrument such as the AirQ that helps recognize risk for future exacerbations may foster an increased willingness for providers and patients to implement a plan that optimizes asthma control. Guidelines recommend recurrent assessment of asthma control to ensure disease stability and positive intervention impacts. While the AirQ has been validated to assess the patient at an annual visit with a 12-month exacerbation recall period, more frequent monitoring of asthma control with a validated tool is an important part of patient care. The follow-up AirQ retains the 7 questions that assess impairment using a 2-week recall, but alters the exacerbation recall period to 3 months from the 3 risk items. As shown here, the only changes made are the wording above the last 3 questions. Thus, the follow-up AirQ retains the readability and the simple yes/no formatting of the AirQ. The follow-up AirQ now offers an instrument to help assess prior interventions. Like the AirQ, the follow-up AirQ shows construct validity for the 3-month look-back period for exacerbations. The proportion of patients with greater than or equal to 2 exacerbations in the prior 3 months were higher with each worsening level of asthma control. At the 6-month assessment, the follow-up AirQ and St. George's Respiratory Questionnaire, or SGRQ, which is a validated measure of health-related quality of life, were assessed. Mean SGRQ total and domain scores were significantly higher, indicating a worsening health-related quality of life as AirQ control category worsened from well to not well to poorly controlled. The follow-up AirQ scores further correlated to patients' perceptions of asthma control, risk to their health, and symptom severity. In addition to the validated versions of the AirQ we just discussed, further educational materials for both clinicians and patients have been developed as recommended by the external precision advisors. A wide variety of educational resources are available in both English and Spanish to help with the assessment and care of asthma. As we come to a close, let's review key conclusions from this presentation. The burden of uncontrolled asthma in the United States is high, with projected future costs being substantial. Variability of underlying airway inflammations places all patients with asthma at risk of uncontrolled symptoms and exacerbations. Patients, clinicians, and impairment-based controlled assessment tools may not always appreciate exacerbation risk and the risk of chronic health conditions associated with chronic corticosteroid exposure. The AirQ assesses both domains of asthma control and can help predict the future risk of exacerbations. And finally, the AirQ may complement current guidelines by facilitating the identification of under-recognized asthma morbidity in clinical practice. Thank you so much for joining me for today's presentation. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933. This concludes this presentation.